ميلادي يا سنة الفجر
وينبوع الشذا العطري
ميلادي يا سنة الفجر
وينبوع الشذا العطري
وملهمتي أناشيدي وآيات من الشعر.
Welcome to this lecture titled The Green Monkey Fever, the Story of Marburg Disease. Today, we begin our journey in the African savannah, where the green monkey lives quietly, far from the laboratories that would later reveal its global scientific importance. This disease, once informally called green monkey fever, became known to the world after a dramatic outbreak in Germany in 1967. In this session, we will explore the history, the discovery, and the medical significance of Marburg Virus Disease, tracing the story from Africa to Europe and into modern clinical practice. Let us begin. Our story begins in the heart of Africa, where the African green monkey lives as part of the natural landscape. For decades, these monkeys carried the Marburg virus silently, without showing signs of illness. This quiet coexistence meant that the virus remained hidden, unnoticed by science, and unknown to the world. It was only when these monkeys were transported beyond the continent to research facilities in Europe that the virus revealed its deadly potential. Understanding this origin is essential because it reminds us that many viral diseases begin in wildlife long before humans recognize their danger. The 1967 outbreak, Marburg, Germany. African green monkeys were imported into research laboratories in the city of Marburg. During routine handling of tissues, laboratory staff were unknowingly exposed to a virus that had never been identified in humans before. Within days, several workers developed severe symptoms, marking the first recognized outbreak of what we now call Marburg Virus Disease. This event became a turning point in the study of viral hemorrhagic fevers and changed laboratory safety practices worldwide. Transmission pathway, how Marburg moved from monkey to man. The outbreak began with African green monkeys that were naturally infected but showed no obvious signs of illness. These monkeys were imported into European laboratories in 1967, where their tissues were handled during research. During this process, laboratory workers were exposed to infected blood and organs, creating the first known human infections. From this single point of exposure, the virus spread from one worker to another, marking the start of the first recorded Marburg outbreak. Clinical features of Marburg disease. Patients typically present with fever, headache, abdominal pain, and profound fatigue within the first few days of infection. As the illness progresses, vomiting develops, a characteristic rash may appear, and the overall condition begins to worsen. By days 3 to 5, some patients enter the severe hemorrhagic phase, marked by bleeding, circulatory shock, and failure of vital organs such as the liver and kidneys. At this stage, patients require critical care support, often in an intensive care environment. The image you see here is the actual electron micrograph of the virus, a long filamentous structure characteristic of the Filoviridae family. Once inside the body, the virus infects and damages endothelial cells, the delicate lining of the blood vessels. This injury leads to increased vascular leakage, widespread inflammation, and a breakdown of the normal clotting system. As the condition progresses, this combination of leakage, coagulopathy, and immune dysregulation contributes to shock and failure of vital organs. Understanding this pathological cascade is essential for recognizing the rapid deterioration seen in severe Marburg virus disease. Diagnosing Marburg virus disease requires a combination of clinical judgment, specialized testing, and strict safety precautions. The process begins with clinical suspicion. Patients typically present with fever, rash, and a rapidly worsening condition, prompting the clinician to consider a viral hemorrhagic fever. Blood samples are then taken and sent to a specialized laboratory for polymerase chain reaction, or PCR, testing. This technique detects the genetic material of the virus directly. Because Marburg virus is extremely hazardous, all diagnostic work must be performed inside a biosafety level 4 facility using full protective suits and controlled air handling systems. The electron micrograph shown here provides a visual reference of the virus itself, confirming its characteristic filamentous structure. This rigorous diagnostic approach ensures both accurate detection and maximum safety for healthcare staff, management, and supportive care in Marburg virus disease. Management of Marburg virus disease is centered entirely on supportive care because no specific antiviral therapy currently exists. The first priority is maintaining circulation. Patients often require intravenous fluids, careful correction of electrolytes, and continuous monitoring of their vital signs. As the disease progresses, organ support becomes essential. This may include stabilizing the heart, supporting kidney function, and ensuring adequate oxygenation. Equally important is strict infection control. Staff must use appropriate protective equipment, follow careful hand hygiene, and dispose of clinical waste safely to avoid occupational transmission. With meticulous supportive care and strong infection control, outcomes can improve even in severe cases. Now we move into the critical zone, the intensive care unit, where survival is determined hour by hour. Patients with severe Marburg virus disease deteriorate rapidly due to overwhelming viral sepsis, massive fluid losses, and multi-organ failure. The first priority is continuous hemodynamic monitoring. This means arterial line placement for beat-to-beat blood pressure, central venous access for vasoactive medications, and close fluid balance tracking to avoid both shock and overload. Next is respiratory support. Many patients develop acute lung injury, requiring high-flow oxygen and, in severe cases, mechanical ventilation with lung protective strategies. Renal failure is common due to shock and direct viral injury. In such cases, renal replacement therapy, either continuous or intermittent, may be required to stabilize electrolytes, acid-base balance, and fluid status. Because Marburg virus spreads through body fluids, strict ICU infection control protocols are essential. This includes full PPE, negative pressure rooms, meticulous waste handling, and minimizing staff exposure. Every action in this environment, every drip adjustment, every suctioning, every medication, must balance the patient's needs with the absolute requirement for staff safety. This is the ICU reality of Marburg virus disease: high stakes, high vigilance, and highly coordinated care. When a patient with suspected or confirmed Marburg virus disease requires emergency surgery, the procedure must be performed inside a fully isolated operating theater. The theater is divided into two zones: a contaminated zone, where the patient and the immediate surgical team operate, and a clean zone, where supportive staff remain protected. All personnel wear full protective equipment, including hooded suits, face shields, respirators, double gloves, and waterproof boots. Every step, from patient transfer to anesthesia to surgical incision, is designed to minimize viral exposure and contain aerosol or fluid contaminations. But these strict biosafety measures protect staff while ensuring that life-saving surgery can still be performed safely during a high-risk outbreak. Anesthetist considerations in Marburg virus emergency surgery. When providing anesthesia for a patient with Marburg virus disease, the anesthetist plays a central and highly specialized role. First, the anesthetist in charge must be experienced in managing high-risk infectious cases and fully familiar with strict isolation theater protocols. A minimal aerosol induction protocol is essential. This requires the use of a face mask fitted with an HEPA filter and carefully controlled techniques to prevent unnecessary aerosol generation. The anesthesia machine setup must be secured and protected. All equipment is wrapped if ISIS is confirmed, and the circuit is fitted with appropriate viral filters. Throughout the procedure, strict barrier precautions are maintained. This includes double gloves, full respiratory protection, and meticulous handling of all clinical waste. These combined measures ensure that the patient receives safe anesthesia while the medical team remains fully protected. After completing emergency surgery on a patient with Marburg Virus Disease, the next critical step is the transfer from the isolation theater to the isolation intensive care unit. This transfer must be tightly controlled. The anesthetist leads the process, ensuring that the patient remains stable while all life support equipment stays securely connected. During movement, continuous monitoring is essential. Vital signs, oxygenation, and intravenous infusions must remain uninterrupted, as even minor disturbances can trigger rapid deterioration. The team operates in full protective equipment, maintaining strict barrier precautions to prevent any environmental contamination during the handover. Once the patient reaches the isolation ICU, care transitions immediately into high-level organ support, infection control, and ongoing stabilization. This transfer pathway is one of the most dangerous phases of management and requires discipline, coordination, and constant vigilance. Complications of severe Marburg virus disease in the ICU. Severe Marburg virus infection leads to a cascade of life-threatening complications, many of which develop rapidly once the patient reaches the intensive care unit. One of the earliest and most dangerous complications is shock, driven by profound fluid loss, vascular leakage, and overwhelming viral sepsis. Respiratory failure is also common. Patients may develop acute lung injury requiring high-level oxygen support or mechanical ventilation. The virus can damage the kidneys, leading to acute kidney injury, electrolyte imbalance, and the need for renal replacement therapy. Neurological involvement may cause encephalopathy, with confusion, reduced consciousness, or seizures. A major hallmark of Marburg disease is hemorrhagic tendency caused by coagulopathy, low platelets, and widespread endothelial injury. Together, these complications create a multi-organ failure picture requiring constant monitoring and rapid intervention by the ICU team. Prognosis and mortality in Marburg virus disease. The prognosis of Marburg virus disease varies widely and depends heavily on the outbreak setting, available resources, and the patient's physiological response. Case fatality rates have ranged from around 24% in early European outbreaks to almost 88% in Angola and close to 100% in some recent clusters. Several factors are associated with high mortality. These include shock, kidney failure, coagulopathy and bleeding, severe metabolic acidosis, and the development of multi-organ failure. Better outcomes are linked to early hydration, timely admission to intensive care, younger age, and the absence of shock at presentation. Ultimately, survival improves with rapid supportive care, tight control of bleeding, and stabilization of organ systems. Now we reach the end of our session. Marburg virus disease, once called green monkey fever, is a highly lethal viral hemorrhagic fever. It was first identified in Germany in the year 1967 after African green monkeys were imported for laboratory use. This virus causes rapid and unpredictable clinical deterioration, including shock, widespread hemorrhage, and multi-organ failure. Diagnosis requires polymerase chain reaction testing in biosafety level 4 laboratories due to the extreme infectious risk. Management remains entirely supportive, focusing on fluid resuscitation, hemodynamic stabilization, and organ support in specialized intensive care settings. In rare situations, emergency surgery may be required, and these procedures must be performed in isolation operating theaters with the highest level of personal protective equipment. Survival depends heavily on early recognition, rapid supportive care, and strict infection control measures. Thank you for watching. Your dedication to learning strengthens the global fight against high-risk infectious diseases.